engine running.
Absolute genius.
Get this.
Welcome.
This is the show where we bring you
Science.
What that essentially means is
discoveries,
Advances.
Questions. Research.
technology.
Unbelievable.
Without further ado,
This is The Naked Scientists. Hello, welcome to The Naked Scientists. This is the show where we bring you the biggest breakthroughs in science, technology and medicine with me, Chris Smith. And this week, how countries across the globe are answering the question, is it possible to end new cases of HIV?
From Cambridge University's Institute of Continuing Education, this is The Naked Scientists.
On today's programme, we're going to examine attempts to end HIV/AIDS as a public health threat by the end of the decade. The AIDS pandemic is unarguably the worst health threat to have confronted the population in the modern era. We believe close to 100 million people have died of the disease so far since it first emerged in the early 1900s. It's proven an incredibly difficult nut to crack. When I first went to medical school in 1993, a patient with advanced AIDS and just weeks away from dying came to talk to us. Now that rarely happens in first world countries these days, thanks to breakthrough scientific discoveries which have created a host of drugs which, when used in combination, can convert the disease into a chronic condition that one just lives with. Regrettably, many countries don't have access to these treatments and they can't afford them. So the emphasis is instead very much on preventing infection rather than trying to cure it. But so far, efforts to develop effective vaccines have failed. This year, in fact, another 2 vaccine candidates failed to make it through clinical trials. Thankfully, the availability of newer drug regimens, including PrEP, pre-exposure prophylaxis, are helping us to turn the corner. This involves using anti-HIV drugs to protect vulnerable people from picking up the infection in the first place. And new, longer-acting forms are becoming available, and they are forming the backbone of an international strategy that's aiming to bring an end to new cases of HIV by as soon as 2030. One of the major frustrations holding back progress, though, is stigma, which is deterring people from getting tested and contributing to the persistence of the pandemic. I've been speaking to Hayward Dikibo, who caught HIV in Nigeria.
It's very scary back in Africa to be diagnosed with HIV. You most times are scared to tell anybody. You're scared of dying. You're scared of everything.
How did you know you had it?
There was a bit of sensitization as to HIV, and I had just left high school, and I just took myself out of fear to the hospital to run a test, and was asked to come back the next day. I initially was given a result that said I was positive, and only to find out that it wasn't my own result. I got like a kind of relief till I saw my result and it came out positive as well. So that was how I found out.
And how old would you have been at the time that diagnosis was made?
I would have been just before my 17th birthday.
Was there anyone you could confide in? Friends,
There was-
other people of sort of similar age, similar situation?
Because of the peculiarity of Nigeria at that time, where the culture of shame and discrimination was really high, still is, there was no one I could talk to. I couldn't even get like an accountability partner. I had to phone in an activist that was in the United Kingdom and to present his number for an accountability partner.
So you couldn't even tell your family, for example?
Oh my, that would have meant me, going through another level of trauma.
So do you think then that this is seriously hampering people seeking testing? Because you were obviously quite forward-thinking and thought, well, I want to know, but there must be people who would think, confronted by those sorts of barriers and risks, they'd rather not know.
Oh yes, it actually poses a limitation because you even find situations where the healthcare providers that are supposed to protect and respect confidentiality also play into stereotyping, discriminating and shaming people living with HIV.
Have you confided in your family since?
So many years ago, I did try to make it open to them and they made a joke out of it, not believing. But yes, since I moved to the UK, I have communicated because I happen to not, I've only been the only person I've waited in also counseling a couple of family members that, found out that they were positive.
I was going to say, did anyone else in your family then come back to you and say, well, actually, I think I might be in the same boat?
Oh yes, some people not coming back to me. They found out, and their stories came out, and I had to encourage them and walk them through the walk.
Hayward Dickibo there, making a strong case for how discrimination and fear drive HIV diagnosis underground, which is inevitably hampering measures to try and control the epidemic, especially in Africa, where the burden of the disease is greatest. In fact, every minute that ticks past on this programme currently marks another 2 new infections, half of them in Africa. So this really matters, especially since UNAIDS have set that target of halting HIV transmission by 2030. Here in the UK, the Terence Higgins Trust, which supports people living with HIV, has also embraced that target, aiming to end new cases in England by the same date. So how are they planning to go about it? Here's Richard Angel, he's the Chief Executive of the Terence Higgins Trust.
The UK government agreed to make the UNAIDS goal of ending new cases of HIV by 2030 a government goal. We, as the charity sector, ourselves at Terence Higgins Trust, our friends at National AIDS Trust and the Elton John AIDS Foundation, came together to create a HIV commission to really give them a blueprint on how they turn that aspiration into reality. The government's response to that was to draft a HIV action plan that took us from 2021 to where we are today. And the newly elected government here in the UK has committed to renewing that action plan to learn the lessons of what's been successful on the reduction of transmissions that's taken place to date and really refocus on the goal of getting to zero and the kind of strategies it will involve to achieve that.
What does the HIV landscape in a country like the UK look like at the moment in terms of numbers and also rates of new cases, etc.?
In the UK, there's about 106,000 people who are living with HIV. All but 5,000 know about it. So the key task in ending the onward transmission of HIV is to find the 5,150 people across the UK that are living with HIV but don't know about it yet. And the trick is to make sure they're testing for HIV. Now, obviously, to test those 5,000 people, you need to test a much bigger cohort and pool of people to do that. Most of that work is done in sexual health services. But we've had some great innovations in recent years that have interrupted people's care pathway and where they're using our health service and inserted a HIV test there. And we found some people who had no idea they might be living with HIV and made sure they are diagnosed and linked to treatment.
What proportion are homegrown and what proportion are coming in?
We've had a anomaly in the most recent years because as the government have changed the visa rules post-Brexit, they have been seeking to attract in workers from countries that have a high prevalence of HIV. So if you're bringing people in from a high prevalence country, it's not surprising if a significant number of them are living with HIV. But the experience overwhelmingly is those people coming to the UK are already on medication and have controlled HIV. So those who are coming into the UK appear in the statistics as people who are kind of new in the UK with HIV, but they're not bringing in their HIV per se, and then crucially, they're not bringing in transmissible HIV to the UK. But we've got about 2,500 essentially newly diagnosed people that had a transmission of HIV here in the UK. And that number is broadly down on where we've been in previous years, but starting to plateau as we get nearer to zero. And the challenge is you need to do more and more tests to find fewer and fewer people.
How are those transmissions that we are home growing and we can't account for on the basis of people who are coming to the UK with a known diagnosis, as you just outlined, how do those transmissions occur and among which groups?
Essentially now is likely to be from people who are men who have sex with men or people who are having sex between men and women. The transmissions amongst intravenous drug users is incredibly low, and the UK has eliminated vertical transmission, which is what we call mother to child transmission, by doing a form of testing that everybody gets in antenatal services when they're pregnant.
Given that you can define and qualify who the risk groups are so well, you must therefore have some pretty clear ideas as to the best strategy to stop this. What is that strategy?
The strategies that work are programs that destigmatize testing for people and encourage people to take up innovative and online, confidential and free forms of testing. So we run a very successful HIV testing week every year that gets 25,000 first-time testers and diagnoses a significant number of people with HIV each year. The things that are starting to work as we are looking for cohorts in smaller and smaller proportions in bigger and bigger population groups are where we're interrupting people's care pathway. So in now 81 A&Es across the country, there is a form of opt-out testing for everyone who goes to an accident and emergency department. And that means that if you are turning up in an NHS setting and you're having bloods taken, you will automatically be tested for HIV, Hep C, and often Hep B. And that has found about 1,200 people who have been living with HIV but didn't know about it. And we're looking to expand that to multi-year programs, but also to other settings, and would like to see anybody who's engaging in a termination of pregnancy or having an abortion automatically be offered a HIV and STI screening test. Those who are using dermatology services to make sure they're regularly tested for HIV. Everyone who goes to the sexual health clinic, make sure they leave without or don't leave without getting a HIV test.
Those are excellent, but also very much reactive to what's gone on. What about the flip side, the proactivity, doing things to stop people catching it in the first place? What sort of strategies have you got there? Because you've got to do that as well as just pick people up and put them on treatment, haven't you?
Absolutely. So there's key tools to preventing HIV transmission. Firstly, that the person living with HIV knows that they're living with HIV, so they can get medication not only for their healthcare, but so they can reduce their viral load and make sure they can't pass on HIV to other people. The second is that those who test negative, they can use condoms to stop HIV transmission if they're having sex. And if they are having sex without a condom, there is a drug called PrEP. PrEP is a drug you might take daily or around a sex-based event that you might be having in your life. And if you take it correctly, it will stop the onward transmission of HIV. And if it were to enter your system, it wouldn't be able to take hold in your cells in the way it would with somebody who doesn't take that drug. So it's a really important tool for people. And we are doing lots of work to promote that going forward. And we're working with the UK Health Security Agency to make sure that those who, particularly AI in the system, might identify as having a PrEP need and need to use a HIV prevention tool, that more of those are getting that need.
How optimistic are you of hitting that 2030 aspiration of eliminating the transmission of HIV? Because as we all know, as you get closer to a target, and we've seen this with things like the eradication of polio, you get to a handful of cases and then it escapes again, or it gets harder and harder to get those last few. Do you think we're going to make it?
I remain an optimist about ending new cases by 2030 here in the UK. And I believe we have the partners in place that share the vision for making it happen. And it's our job to convince them to kind of will the means to get that over the line. But let's be honest, it is possible, but not yet probable. We aren't doing enough as a country to get there. But I think we are in pole position to being the first country in the world to make it happen.
Richard Angel there, the Chief Executive of the Terence Higgins Trust. Optimistic, but realistic. Now, can Australia offer some insights for us here in the UK? Well, healthcare services in New South Wales have managed to successfully reduce new HIV cases in parts of Sydney, where HIV was particularly prevalent, by 88%, describing transmission as virtually eliminated from inner city Sydney. Will Tingle has been speaking to Andrew Grulich, who is an epidemiologist at the Kirby Institute at UNSW, the University of New South Wales.
The unique thing about Sydney in Australia, of course, is that it has been the epicentre of the epidemic, so it has had quite a few resources focused on it. And so if you look around Australia, it probably is the place where there's more funding for community-based organisations responding to HIV. There's more education. The state of New South Wales has a highly organised health system in response to HIV. And there's a great partnership between researchers, community organisations, governments and clinicians, which all have their roles to play in achieving this goal.
Did you find that preventative measures or treatment had a greater impact on the reduction of spread of HIV instances?
I really don't think you can single out one or the other. They're two sides of the same equation, particularly when we have come to realize that treatment in itself is prevention. And that's because once a person with HIV is treated and their viral load becomes undetectable, they cannot transmit. So that's a big part of the success. But the other major part, the other major biomedical intervention we've had in the last decade was the rollout of pre-exposure prophylaxis to HIV negative men. And, we did that in Australia in a somewhat unique way, in that when we saw its promise, in that it's at the individual level, it's close to 100% effective if people take it. The modelling told us that we should introduce it quickly and we should introduce it at scale to try to get everybody at risk on treatment. So we did it in a big bang, if you like, between 2016 and 2019. And even in those 3 years, we saw about a 40% decline in HIV transmission.
The advantage of it being a scheme in inner Sydney, though, is presumably that the population density is rather high. And so you can keep better tabs on things and keep track of things, and there's better availability of healthcare. Do you think this scheme could have the same amount of success if it was rolled out to less densely populated areas, though?
It's not only the urban rural, it's even in the outer suburbs. And we now have a situation, since treatment as prevention as PrEP, where prevention is largely biomedical and requires access to medical care, which, we have pretty good access in Australia with universal health care. But we're finding that fewer doctors outside of the inner city want to prescribe PrEP, and they're not as well informed about PrEP. So the challenge is to train healthcare providers, doctors, nurses, pharmacists, so that they know about PrEP and they will be advocates for PrEP, because at the moment we're finding it's too hard for gay men in those outer suburbs and in the country to get themselves and keep themselves on PrEP. I think we've got to also address the stigma that people hold towards people with HIV, and even self-stigma. But if we could address the stigma and if we could provide better health services, then I think we would be a very, very long way towards elimination.
So big picture, do you think that elimination of HIV is possible by 2030?
So really important that we understand that when we talk elimination, we're not talking about no virus being left in the world, because HIV is a condition which can exist in an asymptomatic state for a decade or more. Formal elimination, as in no more virus, as we've got for smallpox, is not possible. In fact, the United Nations AIDS Agency definition is a 90% reduction in new infections. We are virtually there in inner Sydney. And I do believe we can reach that by 2030 in Australia.
Andrew Grulich, he's at UNSW in Sydney.
The Naked Scientists podcast is produced in association with Spitfire, cost-effective voice, internet and IP engineering services for UK businesses. Find out how Spitfire can empower your company at spitfire.co.uk.
Music in the programme is sponsored by Epidemic Sound, perfect music for audio and video productions.
And you're listening to The Naked Scientists with me, Chris Smith. And this week we are looking at how countries around the world are adopting strategies to combat the spread of HIV to meet the UNAIDS target of halting transmission of the infection by 2030. Now, one continent stands out as bearing the brunt of HIV disease, and that's Africa. It accounts for 2/3 of the world's AIDS burden, with 27 million people living with the virus, and most of them live in the south, with disease prevalence being particularly high in Lesotho, Botswana, Zimbabwe, Eswatini and South Africa. Now, in the latter case, in some locales, as many as 1 in every 2 young black women attending antenatal clinics are testing positive. So why is this so high, and what measures can be brought to bear to stop that level of spread? Saleem Abdul Karim is a world-leading epidemiologist and virologist at the University of KwaZulu-Natal in South Africa. He also chairs the UNAIDS Scientific Expert Panel.
Globally, we are seeing a steady trend in HIV of declining incidence rates and prevalence. And that's true as much in Africa as it is in most other parts of the world. However, at a global level, there are 3 groups where incidence has been somewhat more recalcitrant. One of those is in Southern Africa. Now, Southern Africa comprises about half of the global epidemic. And within Southern Africa, South Africa accounts for about 1/5 of the global burden of HIV. And within South Africa, the group that's at the highest risk of HIV are young women.
Is the reason that South Africa has such high prevalence because it's also slightly unusual amongst African nations in being quite moneyed, and therefore one of the few countries that could afford quite aggressive treatment for HIV earlier on in the pandemic, and so you've kept people alive and well who otherwise might not have been in a less well-developed setting?
In most of Southern Africa, the high rates of HIV in young women are being driven by what is referred to as age-disparate sex. Put another way, this is about teenage girls who are having sex with men who are about 10 years or so older than they are. Put another way, we have what we call the cycle of HIV transmission. Men in their late 20s, early 30s are having sex with these teenage girls, so these young girls below the age of 25. These young girls then grow up, and when they reach their late 20s and 30s, they have a very high prevalence of HIV. In some communities in KwaZulu-Natal, over half of the women in their 30s have HIV. These women are now having sex with men that they are going to marry as their husbands or their long-term partners. And so these women then infect men in their 30s. These men in their 30s have sex with teenage girls. They infect the teenage girls. Those girls grow up. When they reach 30, they infect the next group of 30-year-old men who infect the next. So this cycle continues. And the problem you have is that when you look at the technologies to prevent HIV, what you used to euphemistically call the ABCs, abstinence, be faithful, condoms, and circumcised, those technologies essentially are under the control of men. And so we didn't really have technologies that women could use to control their risk until along comes PrEP. PrEP, pre-exposure prophylaxis, is used in over 100 countries throughout the world, and it now gives women the power and the ability to control their risk of HIV. A challenge, though, is that it's very hard for somebody, especially a young teenage girl, to contemplate that she's going to get HIV, and so she better go and take a tablet, better go stand in the queue, take the bus, go to the clinic, get the tablets that she's got to take every day. Now, that could possibly change because we have newer technologies, in particular, an injection that you can take once every 6 months. This particular injection, if taken once every 6 months, it was shown to be 100% effective in young women. That's a very powerful tool.
Is there a risk, though, that if people use things like these pre-exposure prophylaxis approaches, that they are then less careful and you prevent one disease, and HIV is very important, yes, but are people then placing themselves at risk of others because they're not using condoms, other barrier methods, for example?
In most of the places where we do reproductive health promotion, it does not lead to everybody just having sex. But what does happen is that when these educated individuals do have sex, they understand the importance of protection. Now, we have seen with pre-exposure prophylaxis that there are, in certain instances, a situation where we see an increase in the prevalence of gonorrhea. In other words, we are seeing sexual activity and we are seeing a risk of other sexually transmitted infections. But overall, the key goal, which is to reduce the prevalence of HIV, which is the disease that can't be cured, the focus is on trying to bring down the number of new infections with HIV.
You mentioned earlier the role that circumcision can play it's gone a bit quiet on that front because a lot was said about that about 10, 15 years ago when these various manoeuvres were put in place to try to do this. How's that working out? Has that made a difference?
So, 3 clinical trials undertaken in the early 2000s all showed quite consistently that circumcision is effective in preventing HIV in men. Protection at around 60% or so. So, on that basis, huge programs were put in place to roll out circumcision. And when we rolled out circumcision, we rolled it out to those men who we thought were at highest risk. But the uptake is a challenge. And what we found was the ability to roll it out at scale was a challenge. To start doing hundreds of thousands of circumcision is not easy to do. So circumcision has had a role to play in particular communities where a circumcision can make a difference. But as an overall population strategy, it has not been as effective as we would like it to be. And so that's why newer technologies like pre-exposure prophylaxis become more important when we are now aiming towards the 2030 goal of ending AIDS as a public health threat.
South Africa's Slim Abdul Karim. Now, as Slim was just explaining, the southern region of Africa, the epicentre of the epidemic, faces unique problems, including a very high caseload among adolescents and young women. So what are the solutions? Well, we put in a call to Bahuma Tatanji, who's a Cameroonian-born doctor and infectious disease specialist at Emory University. She told us what we do and what we don't have in our arsenal when it comes to fighting the spread of HIV.
One of the biggest barriers remains the fact that we don't actually have a vaccine that effectively prevents HIV acquisition. So what we really have at our disposal remains getting as many people who are living with HIV on antiretroviral therapy, but also being able to provide pre-exposure prophylactic modalities to individuals who are at higher risk for acquiring HIV. And we're not hitting the targets where these are concerned.
What sort of levels are we getting to?
Most countries in Africa are approaching the 80% treatment coverage targets for adults. But it's important to note that when it comes to pediatric HIV, that number and those targets are unfortunately not being met, with only about 50% of children living with HIV in Africa currently being on antiretroviral therapy. Where pre-exposure prophylaxis is concerned, the numbers there are a little bit more dire in terms of the regions hitting their targets and actually getting pre-exposure prophylaxis readily available to populations that are most likely to benefit. In Eastern and Southern Africa, these targets are on track to meet the goals that were set to be achieved by 2025. But in West and Central Africa, we still have significantly low levels of PrEP coverage. The target for PrEP coverage set for 2025 was the hope to get 21.5 million people on PrEP, but currently there are only about 3.5 million people who are receiving pre-exposure prophylaxis for HIV.
What's the barrier to getting to the number we want? Why are we at the number we currently are?
I would think that one of the biggest barriers is really there's still a lot of stigma and discrimination that is associated with having HIV or being someone who is in a group that may be at higher risk for acquiring HIV. Additionally, there have been issues around funding for pre-exposure prophylaxis, with some countries not necessarily having the requisite resources to actually make these prophylactic treatments available on a broad scale. In terms of meeting the targets for treatment, the biggest barriers remain testing people and actually having people know their HIV status.
What do you think we can do about this? Where do you think the solution lies? Because you've outlined what the frustrations are, but it's not obvious what we do then to solve that.
One of the key developments that gives me a lot of hope is the advent of long-acting PrEP modalities, which bring with them a layer of flexibility in terms of options and choice for people who are likely to benefit from pre-exposure prophylaxis. Now, having this degree of flexibility and choice means that you are removing barriers, either people having to go to a healthcare facility to be able to pick up medication, or just being able to use pre-exposure prophylaxis in a manner that is more discreet than having to take a pill a day.
Is this a short-term sticking plaster, or is this part of a longer-term strategy to try to bear down on transmission and ultimately stop it? Or is it both? Because one could see that if we could drive the number of people who are actively acutely infected right down, we actually really do slow down the transmission of the disease, because people are most infectious with HIV when they're first infected.
That is absolutely correct. I think that it is both, but I would caveat that with the fact that we've now had pre-exposure prophylaxis for 12 years in the form of a once daily pill, and still we're seeing approximately 120,000 new infections of HIV in Western and Central Africa per year. Now, although the modalities that I have described hold the potential of reducing transmissions, they would only be able to have maximum impact if we're actually able to get them to the people that need them. Additionally, to your point about people with low viral loads or undetectable viral loads not being able to pass on the virus, that's why it's important that even if we're focusing on pre-exposure prophylaxis to prevent acquisition of HIV, we must also ensure that we are effectively treating the people who have HIV to make sure that their viral loads are undetectable so that they also cannot transmit.
Is there a risk when we give wide-scale use of drugs, in the same way that with antibiotics, the more we use antibiotics, the more antibiotic resistance that we're going to see? If we are not careful with how we deploy drugs at this problem, there is a chance we could accelerate the rate of antiretroviral drug resistance, and therefore we could pull the rug from under the use of those agents, not just in the African countries where they're being deployed, but potentially all over the world if those resistant forms spread.
That is absolutely correct. And we have already seen reported in the clinical trials for some of the long-acting preventative modalities that exist, reports of individuals who have acquired drug resistance to these medications when they acquired an HIV infection while using them. Reassuringly, the rates of this occurrence have been low. And I think that with having long-acting pre-exposure prophylaxis, the one thing that we get is we know that the individual is taking the drug, because unlike the pills where you're really relying on an individual being able to take one pill every day, oftentimes in unsupervised settings, and you're trusting them to adhere to the therapy to maximize its effectiveness.
Are you optimistic in terms of where we are at the moment with the interventions we do have and the challenges that you have outlined that we need to surmount but are surmountable? Do you think we're going to get there?
I am cautiously optimistic. I think that we have the tools to effectively stop HIV transmission, but whether we have the will is something that remains to be seen. And I think that a huge part of that will is being able to bridge the funding gap that would allow us to actually implement these tools and strategies and get them to where they are able to have maximal impact.
Infectious diseases specialist Bahuma Titanji there from Emory University. It's now over 40 years since HIV was discovered and confirmed to be the cause of AIDS, the immune deficiency syndrome that characterises the infection. In that time, we've battled very hard and so far failed to develop vaccines to stop the spread of the disease, which has so far killed millions of people. But I come away, having listened to the sentiments and the perspectives that we've heard this week, feeling more positive than I have in a very long time. There's a stronger optimism and sense of purpose and direction, and a way to achieve the end goal of stopping HIV spreading worldwide in the next decade. Let's hope we can achieve it. That's it for this episode. It just remains to say how grateful we are to Nadine Tambwe, who's a PhD student with the ICGB in Cape Town, and she's been doing a special internship with us. She put this whole programme together. Thank you, Nadine. Next week, we are going nuclear. We'll look at its future and the role it will play in meeting our energy needs, both here on Earth, but also up in space. Don't miss it. The Naked Scientist comes to you from the University of Cambridge's Institute of Continuing Education. It's supported by Rolls-Royce. I'm Chris Smith, and from all of us here at The Naked Scientist, thanks for listening, and until next time, goodbye.